Thank you very much for the invitation and for this opportunity to talk about drugs in ACS post-discharge. I hope that I try to control the slides.
Professor Roeters van Lennep, you have control. There's sometimes a lag. If you have a problem, I can take control. Please let me know how you'd like to proceed.
I think that you have to do it for me because it doesn't work, or the lag time is so huge that... So can you proceed to the next slide, please? Yes.
Sorry.
Oh yeah, these are my disclosures. Next slide, please. Yeah. Well, post-discharge drugs in ACS can actually be summarized into the big five. But of course, it are not these big five that we know of, but next slide, please. This big five, and these are the big five according to the ESC guidelines. And these consist of the 5 drugs that should be given to all patients who have had an ACS. And as you can see, they're all class 1 level A evidence. And the first one is dual antiplatelet therapy consisting of aspirin and a P2Y12 inhibitor. Then lipid lowering drugs, of which statins are the first line of therapy, ACE inhibitor or an ARB, and lastly a beta blocker in patients who have systolic left ventricular dysfunction or heart failure. Next slide, please. Yeah, the key features I would like to address in this short presentation of 10 minutes are the importance of prescription of guideline-directed medical therapy, the importance of adherence and the difficulty of that, and also some future intervention strategies which can help us. Well, first of all, it all starts with the prescription of the guideline-directed medical therapy, and it sounds so easy, and it should be. But this study of almost 20,000 patients with acute coronary syndrome who underwent the PCI shows that at discharge, more than 30% of the patients did not receive their big five. And it depends on the drug, because aspirin is the most prescribed drug in 99% of the patients, but this declines to 70% of the patients receiving an ACE inhibitor or an ARB. Next slide, please. But not all patients have the same opportunity to receive guideline-directed medical therapy. So that means that you have a higher chance to receiving your big five if you're white, if you're a man, if you're younger, and if you do not have comorbidities. So that means that this patient, the left patient, will have a higher chance of receiving his guideline-directed medical therapy and not the other elderly black woman. But what's the reason for that? And there's also this myth that, for example, that DAPT will not, dual antiplatelet therapy is less effective in women, and that women will have a higher bleeding risk. Next slide, please. And recently we performed a meta-analysis comparing high-potent P2Y12 inhibitors, DAPTs, compared to DAPT based on clopidogrel in patients with ACS. And what we showed is that high-potent DAPT is equally more effective compared to clopidogrel DAPT, both in men and in women. And comparing with that with bleeding risk, next slide, please. We showed that there was a non-significant increased risk of bleeding associated with high potency DAPT, both in men and women. So actually, there's no really good reason to withhold high potency DAPT in women. Next slide, please. So then, well, if we have had the first step of prescribing medication, then the second step is that patients really have to adhere to the medication. And also that is in the long term is a problem. And I think that we all recognize this. This is a study which showed the post-myocardial infarction adherence of statin and ACE inhibitors in more than 4,000 patients. And it was shown that only 43% of the patients took their medication 80% or more after 4 years. And what is very evident is that in those patients who took their drugs had a lower incidence of having another event compared to the patients who were partly adherent or were not adherent at all. But it's not only a matter of having an increased risk of events, but also, next slide please, it's a matter of costs, because those non-adherent patients cost us more, the society, compared to fully adherent patients, and the difference is about 30%. So next slide. So the problem is, and well, the patients are not adherent, and how can we change that? And I think that we need new approaches, because of course, we tell them that they have to take their pills, but for some reason it's very difficult for them to do so. I will now proceed with describing two intervention strategies. One of them is nurse-based, and also they're very interesting new e-health interventions upcoming. Next slide, please. Well, this is an example of a nurse-based intervention strategy of more than 1,000 ACS patients who were randomized of just a control and intervention, and the control was regular treatment by the physician who prescribed the drugs and had an annual follow-up up till 5 years post-discharge. And the intervention consisted of a nurse guide discussion of lifestyle and risk factors, and also every month personal medication adjustments, and it was really based on their blood pressure and on their blood levels. And what was found, go back, is that after 5 years, the patients who had the intervention and had a regular discussion with the nurses had a higher adherence compared to the patients who got the regular treatment. And in this case, the outcome was the adherence to statins. Next, please. But also there are very exciting new e-health interventions upcoming. And one of them is a study that was in a small group of patients, 130 patients with ACS, and it was based on a behavioral economics intervention. And in this case, it was the adherence of aspirin. And patients, if they took their aspirin every day, they could earn $50 per month. But every time they missed a dose, $2 was subtracted from this amount. And they showed that the adherence was 90% in the patients with the interventions versus 80% in patients without intervention. And even after 90 days, the rehospitalization rate was far lower in the patients with the intervention compared to the patients without the control. And next, please. Yeah, and this is also very exciting. This is a new upcoming intervention. It's a gamified health intervention with an app, and it's based on the health access process approach, the HAPA, and it's a theoretical framework, and it really goes back like, why do we things and why, in this case, don't we do things? And it consists of a motivational phase in which individuals form interventions to perform certain behaviors, and a volitional phase which describes how these intentions are translated into behavior. And this theoretical framework is used in this app, and this app consists of a story of a journey in the mountains, and every time the patient reports the medication intake, a new section of the story is revealed. And you can also get bonus episodes are unlocked if you answer quiz questions about awareness of medications, but also about risk factors. And I think that these kinds of new ways are maybe a move forward to improve adherence. Next slide, please. So I think in the end, guideline-directed medical therapy, it consists of drugs which are proven to reduce cardiovascular disease events. They're very not expensive. So why don't we do that? prescription, it's not rocket science, we can all do that, but still, I think that it's important to notice that right now, not all patients receive it, so it's very important for healthcare professionals to make sure that all patients receive, with ACS, receive GDMT. Next. And also adherence, taking pills every day. It's not rocket science to do this, but adherence is a huge problem regarding events, but also economically. So maybe new concepts can help us in the future to improve this. Well, thank you very much, and I'm happy to take every question you might have after my presentation.
Okay, thank you very much, Jeanine. It's an excellent presentation again. We have a few minutes for discussion. May I ask Kurt Huber first this question? Kurt, imagine a patient with no risk factors, atypical symptoms, maybe atypical chest pain, T-wave inversion on the EKG, so an EKG which is not very contributive, and a negative troponin when you get the first result of the blood sample. So the likelihood of having a non-ST elevation ACS is rather low. This patient is going to receive probably aspirin, but are you going to give also anticoagulation to this patient at the time of admission? Or would you wait for confirmation, for example, at the time of the coronary angio?
No, if you talk about anticoagulation, so in this specific situation where we don't want to rush to the cath lab, so I would not in every case give an anticoagulant here. So I'm happy with the aspirin the patient has. The main problem is not that it's my decision, so it's frequently decision of the ambulance system, of the doctors working there, and they have some kind of a reflex that they give the patient aspirin and in addition unfractionated heparin. But if it's a patient I would see in emergency room, I wouldn't give him immediately an anticoagulant if this is more or less a stable situation.
Yes, I tend to agree, and the North American guidelines tend to say also when you have a low likelihood for non-ST elevation ACS in your working diagnosis, aspirin alone is enough. But we have the chairman of the guidelines here. We may ask him what he thinks about it.
So we have stated in the guidelines that the first-line therapy should be aspirin and also parenteral anticoagulation if there is no anemia, which means that you should wait for, the blood work, before, starting any intensive treatment. So, so it's rather wait and see instead of rushing if we are on the, low risk side.
Okay, thank you very much, Jeanine. I have a question for you. You mentioned statins, of course. And it's part of the big five. What about the other drugs to control this type of patients in secondary prevention? What about the timing of ezetimibe, for example? What is the place left to expensive drugs like PCSK9 inhibitors? You have here the guidelines in STEMIs published in 2017. And as you can see, this is the old recommendation, which is obsolete now with a target of 70 milligrams per deciliter. And on the next slide, you have the NSTEMI guidelines, which were published last summer with an adjustment to the dyslipidemia guidelines with a target, which is very difficult to reach with statins alone. So what is your recommendation for the other drugs? Ezetimibe, is it immediately at the time of hospitalization? Shall we wait and see the patient back in the consultation? What is your recommendation for the expensive drugs, PCSK9 inhibitors? Shall we wait, or shall we, use them maybe early, as it was done in 2 studies already, small studies? Evopax is one, EVAX is another one, and you get a rapid decrease of LDL. Is it important to get this LDL down rapidly? Jeanine.
Well, thank you very much for this question. I think it's very important, first of all, to start with a baseline LDL. And of course, I'm a vascular internist, and the cardiologists are very quickly to start their drugs, which is excellent, of course, but it's also very good to know what the starting point is. Also, because, well, some patients might have a specific reason why they have the ACS, especially if they're young, if they have a hereditary form of hypercholesterolemia. And also there you can see, if you know the baseline LDL, you can kind of predict what you need to reach the targets. So if a patient comes in and has an LDL of 2.6, then it's very likely that you will reach the target levels with statins alone. But if he has or she has a very high baseline LDL, you might as well start with combined therapy with statin and ezetimibe. And both are off patent, so are very cheap. So I don't think there's any reason not to really titrate the treatment. Regarding PCSK9 inhibitors, I think that if you do not reach the target levels with optimal statin therapy combined with ezetimibe, then there might be a place for the next step. But also it's very important there to look at the whole profile of the patient, and also, of course, take into account the local reimbursement criteria of the country that you're living in.
Okay, thank you very much, Jeanine. It's a very useful answer to this question. So what I suggest, because I'm watching the clock, we are perfectly on time, and I wish we stay on time. So we're going to move on to a case study, which is the first case study that will be presented at this ACS forum, and I'm going to ask Miklos Rola to present his case.